Hi friends, a very good evening to all of you. I am Dr. Pallavi Shah, Project Chairman of National Medical Awareness Seminars. The first session of the series on diabetes left a sweet taste in the mouth of the participants. Today, I welcome all of you to the second session of the awareness seminar on cardiology by Association of Inner Wheel Clubs in India and sponsored and hosted by District 314. Friends, in the last session, we had to close wishing that we could have had more time with the doctors. So without much ado, I request Association President Surjit Kaur to call the session to order.
I call the second session, Cardiology of National Medical Awareness Seminar, hosted by District 314 to order.
Please stand where you are. District Secretary Prerna Raichur will recite the Inner Wheel prayer.
Instill in us, O Lord, the true meaning of friendship. Never let us forget that we are all thy children. Notwithstanding the differences in our cultures and creed, endow us with a desire to serve our fellow men, remembering that we too often need help whenever or wherever the need for service arises. Help us to be ready to serve, endeavoring to make our badge of inner wheel worthwhile, ensuring that we have not lived in vain. Thank you.
Thank you, Prerna. Now, our association president, Dr. Surjit Kaur, is a gifted, glamorous, glorious, gorgeous, graceful gynecologist from Jammu and practicing in previously princely city of Kapurthala called Paris of Punjab, known for its French architecture. Now better known for agriculture because of its location between Satluj and Bias. Our multifaceted association president, Dr. Surjit, will welcome all.
Thank you, Dr. Pallavi. I wish I was all that you said I was. Anyway, thank you very much. A very warm welcome. A very warm welcome to our esteemed medical faculty, our very gracious Inner Wheel dignitaries who have joined us today, dear members and all participants. Again, a little bit about Inner Wheel. For those who are not members here, Inner Wheel is the largest voluntary service women organization in the world, spread over 100 countries with over 4,000 clubs and over 1 lakh members. More than 53,000 members are from India, which makes us the largest association in the world known for friendship and service. So you see, so many hands to serve. This medical session on cardiology by Dr. Akshay Mehta and Dr. C.K. Pandey is going to be the listener's delight, I assure you. I myself, being in the medical profession for the last 45 years, never found medical webinars so delightful. Probably it is the Inner Wheel magic.
Thank you, Surjit ji. Friends, this medical awareness seminar is hosted by District 314. No words are required for the dynamism of District Chairman Meeta. Her work in these 3 months have been loud and clear. The ebullient, enthusiastic, elegant, energetic, eloquent District Chairman Meeta will take you with us to share with you the way we made choices for this seminar. Meeta.
Thank you. On behalf of the District Executive Committee members of Inner Wheel District 314, I, Meeta Sheth, District Chairman, welcome each and everyone here, Association President and International Inner Wheel Executive members, Association Executive members, my co-district chairman team, IIW, past presidents, past association presidents, past district chairman, presidents, and all my Inner Wheel friends, and last but not least, our esteemed doctors. The pandemic caused by the virus is certainly the biggest challenge to global health today. It has changed the profile of many, many diseases. The silent killers like diabetes, hypertension, heart attacks were not so silent and affected younger people. Mental issues of health were rampant, particularly amongst the younger generation. There is a general scare and myth amongst the general public. We at Innerwheel decided to address this and approached many learned and experienced academicians. Members can personally benefit and help to educate their near and dear ones. This led to lectures as interactions under the banner of Association of Innerwheel Clubs in India, and we in District 314 decided to host the seminars. Project Chairman Dr. Pallavi Shah and I were joined by many others to carry forward this idea. The National Medical Seminars with eminent doctors are an endeavor to educate and empower us on health management. Thank you.
Thank you, Meeta. I thank Association President Surjit and District Chairman Meeta for being brief so that we can have maximum time with the doctors. Friends, before we begin with the learned doctors, I have a couple of announcements. We will have interactive session after talk by both the doctors. You are aware that you may write your questions on the chat during interactive session, the doctors will answer your questions. Write your name, the name of the doctor you wish to put the question to, and then the question. I think you all are expert by now on this. Secondly, this time we have planned to applaud the best listeners. Please sit with your mobile phones or an extra mobile of your dear one. After vote of thanks and then national anthem, the questions will be put up on the screen and left on the screen for 3 minutes. Take a screenshot or a picture of the questions and send the answers on the email ID that is given on top of the questions. The Awareness Seminar Committee have decided to award the 3 winners, and District Chairman Meeta will also recognize them at the district conference. I invite Dr. Yogini Sheth to introduce Dr. Akshay Mehta.
Thank you, Dr. Pallavi. Good evening, friends. I have the honor of introducing Dr. Akshay Mehta, a man with a golden heart. He has worked for the last 35 years tirelessly to save lives. To him, every emergency calls for quick action in the high tradition of medical practice that the profession demands. He passed his undergraduate and postgraduate from GS Medical College, Mumbai, and worked in KM Hospital. Dr. Mehta is attached to Nanavati, Max, Beach Candy, and Holy Family Hospital, where he has done thousands of coronary interventions. He is an active charter member and president-elect of Rotary Club of Bombay Airport. He is honorary secretary of the Academy of Cardiology, Mumbai. Dr. Mehta has published several papers in journals and is invited as a faculty member in many conferences. He has conducted many workshops in CPR. Dr. Mehta is a multi-talented and co-authored 6 books for cardiologists, as well a book on coronary heart disease for laymen, which is named Romancing the Heart. This book has endorsements from respected DK Shivani, Shri Amitabh Bachchan, Dr. Devi Shetty, and Shri Sunil Gavaskar. He has contributed several articles on heart health in the Rotary News International magazine. His articles regularly appear in the Times of India, and he's writing a series in the Gujarati newspaper Janmabhoomi. Today, he will be talking about, does a woman's heart beat differently? While I let him answer that question, I am personally grateful, as today my husband's heart is beating strong and pumping well and has learned to romance. Thanks to Dr. Akshay Mehta. Thanks to his incredible expertise. Dr. Akshay, Dil Ki Baat, Dil Se Karenge. I invite Dr. Akshay Mehta for his presentation.
Dr. Akshay, all the participants are waiting with bated breath to hear you. Women to know how their heart is different, and men folk want to know how to romance that different heart. Dr. Akshay Mehta.
Thank you, Dr. Yogini, for that excellent introduction. And thank you, Dr. Pallavi. And welcome all of you. Great pleasure to be with you all. A few months ago, when the International Inner Wheel past president, Dr. Pallavi Shah, contacted me to have such a meeting on the World Heart Day, I immediately agreed, because I thought, what better way to celebrate World Heart Day than to talk about women's heart to the leading women of the country, the inner wheel. And, as it is, women have received a little bit of a second-class treatment as far as heart disease is concerned. And I thought it is time to correct that mistake. And hence, I grabbed this opportunity. And I'm very happy to be with you all and to be given this the privilege to talk about women's heart disease. So I thank Dr. Pallavi, of course, and Association President Dr. Surjit Kaur, District Chairman Meeta Sheth, coordinators Dr. Sonal Raje and Dr. Yogini Sheth. And of course, I welcome a lot of friends in the group that I can see, Dr. Amla Mehta and Dr. Pallavi Choksi and so many others. So now we'll get on with the talk, and the talk will see that way women have different types of heart disease peculiar to them. But I will be restricting, because of the time, to the most important disease, heart attacks and coronary heart disease. So let us start with, if I can share my screen. I hope you can see the screen. Can everybody see the screen, please?
Yes, we can.
Yeah. Okay.
Yes.
Yeah. Okay. So heart of a woman, does it beat differently? So I start with what, by the way, I'm going to intermittently ask questions so that to keep you alert, and you can answer them in your own mind. You be the judge for yourself, and the correct answer also I will give, so that we don't waste too much time. So the first question is, which is the #1 killer of women all over the world? Is it breast cancer? Is it all cancers combined? Is it heart disease or suicide? Well, the correct answer is heart disease. And heart disease is the #1 killer of women, killing more women than all forms of cancer combined. Also, a woman is 10 times more likely to die of heart disease than breast cancer. So that important heart disease is for women, right? Now, I would like to see you all to see this small clip, which came some years ago, but which I like very much. And this guy reading a newspaper has collapsed. He's being taken to the emergency. And then the other guy wonders what happened, and he also reads the newspaper. Maybe there was some news from the stock market, and he also collapses. So the question is, what was this? A heart attack, cardiac arrest, or something else? Well, if you say it is a heart attack, that is not correct. It is sudden cardiac arrest. It's extremely important for you to differentiate between these two conditions. And why is that so? Why is it important to know the difference between heart attack and cardiac arrest? Because you as a bystander or you as a relative of a person who has had such a thing, your response has to be different in both these situations, which we shall see, right? Now, let's go back to our school days when we learned that the heart is a 4-chambered organ, 2 upper chambers, 2 lower chambers. The lower chambers are the dispatch center chambers which send out blood, out of which the whole drama of heart attack and heart disease majorly occurs in this chamber called the left ventricle. With every heartbeat, the muscular walls of the left ventricle pump blood out to the entire body through this large tube called the aorta. Now, to make it very simple, I have made a small diagram like this, which shows that the heart muscle with every heartbeat pumps out blood through a large pipe called the aorta to the entire body. Now, like every muscle in the body, the heart muscle also requires oxygen and nutrition. And it gets this nutrition and oxygen through the branches of the aorta called coronary arteries, which lie over the surface of the heart muscle and supply the muscle with nutrition. So these are our lifelines. And basically, we have 2 major arteries, the left and the right coronary artery, and its branches will lie over the surface of the heart muscle and supply it with nutrition. I hope till now things are clear. Yes?
Yes.
Okay, now when we were born, if we slit open our coronary arteries, they will look like this, with a nice big passage and a smooth inner lining. Or if you cut them vertically, they look like this. But as we grow, and if we have some risk factors like hypertension, diabetes, cholesterol, smoking, etc., some fat deposit starts laying down in the inner lining, and which makes the lumen or a passage narrower and narrower as time goes. So this could be a gradual process in some people, but in many people, this process is interrupted by a sudden event, which is due to complete blockage of this artery. So why does this occur? For example, you have a coronary artery with a diameter reduction of, say, less than 50% or 50%. Such a person with a 50% narrowing may not have any symptoms. He may be walking around. Even his stress test can be normal, and he doesn't know he has a blockage. Now, what happens due to certain stressful situations, this cap or the covering of the fatty plaque or a fatty deposit in the artery can break. And if it breaks, like the boil on a skin, which forms a scab over it, in the same way, the fatty plaque can break, and the blood that is flowing in the artery can start clotting to repair that plaque. And if this clot is very big, it could completely occlude the artery, and the blood flow can stop completely within minutes. So a 50% block, which did not cause any problems, can become 100% within minutes. And this blockage causes a heart attack. So what happens when there is a heart attack? A blockage in one of the arteries stops blood supply to a portion of heart muscle which starts dying. So this damage and death of a portion of the heart muscle is heart attack. And that causes chest pain as the most common symptom. The person's heart is beating, the person is conscious, can go to the hospital, but about 1/4 or 1/3 of such patients can have a cardiac arrest in the first hour after a heart attack, which the cardiac arrest is a different thing, but most of these patients can reach home with chest pain. Okay, I hope this much is clear. Yes?
Yes.
Okay, now this is the most important slide for you all to see. As I said, the coronary artery, this is the coronary artery, and here we have a coronary artery. The blockage occurs within few minutes, but the damage it causes to the heart muscle takes a few hours to complete. It may take 6 hours, 8 hours, 12 hours, 24 hours. So that gives us a window of opportunity. And that means that if we open this block and allow the flow of the coronary artery, the blood to flow through the coronary artery, we can minimize the damage. And the earlier we open, the lesser the damage. For example, we open the artery within say 1 hour of chest pain, then hardly any damage will occur to the heart muscle. But if we open the artery after 12 hours or 24 hours, a lot of damage would have been done and the benefit would be less. So opening the artery is extremely important to save the heart muscle. And how do we do that? There are two methods. One is to inject a clot dissolving drug, which dissolves the clot, or do an emergency angiography and insert a balloon and a stent and open up that block so that the artery, the blood flows smoothly through the artery. Sometimes we do both. We inject the drug and after a few hours do the angioplasty. So all that decision has to be taken by the patient and the relatives, rather the relatives with the doctor, according to the situation. So when the block is removed in time, a very minimal amount of heart muscle is damaged and a major portion of the heart is saved, and the person can go home without much complications which can occur, like thinning of the heart muscle, dilatation and heart enlargement. You may have heard of patients whose pumping has reduced and heart has been enlarged after a heart attack. So this can happen. So summarizing heart attack, it is due to blockage of an artery. It causes death of a portion of heart muscle. It causes chest pain. And the treatment is to hospitalize the person as soon as possible to open the artery, right? But the question is, the most important thing is, how do you recognize that you've got a heart attack? And secondly, what action to take, which should be within minutes. So how do you recognize a heart attack? Well, one question. Heart attack starts as a severe pain in chest. True or false? Right? Well, the Bollywood type of heart attack in which there is sudden severe chest pain is not true. What happens is that most heart attacks start as mild or moderate discomfort in the chest, which increases within minutes and becomes more severe later on and lasts for more than 10 to 15 minutes. So many times this moderate discomfort may be ignored, and that is why many times patients come late to the hospital, right? So what does it feel like? The chest pain feels like uncomfortable pressure, squeezing, fullness, tightness, pain, or even burning. And there is difficulty in breathing. One feels that there is a tight bear hug on the chest or an elephant on the chest. Additionally, there may be sweating, vomiting, or a cool skin. And less commonly, there may be feeling of gas, lump, indigestion, or burning in chest like acidity. And where does this discomfort occur? Well, most commonly in the center or left side of the chest or both sides of the chest. It occurs over a large area. It doesn't occur over a small area which you can point with the finger. Usually it is denoted by the palm of the hand over a large area, but it can occur anywhere from the ears to the navel and from one hand to the other hand, and sometimes only in the back of the chest, the upper back. So these are the places where the pain of heart attack can occur. Now, another question. After a heart attack, death and complications due to the heart attack are more in men than in women, more in women than in men, equal in both, or they are not there in any of the genders. So what is the correct answer? Where the correct answer is that though heart attacks are less common in women, the complications are more in women than in men. That is a very important thing. Okay. So if a woman has heart attack, we have to be more careful. The complications are more. Even the complications are more after angioplasty or bypass surgery in women than in men. And why is that so? Well, one reason is the symptoms. Though the most common symptom of a heart attack for both men and women is chest pain, some women have different symptoms, and we call them a little misleading heart attack symptoms. For example, they have a pain in arms or upper back or jaw and neck and not have chest pain. Or they may have just shortness of breath or extreme fatigue or severe nausea and vomiting all of a sudden, or stomach discomfort, the upper part of the stomach. So these symptoms mislead us, not only the patient, the family also, and hence there is a delay in contacting the hospital or the doctors, and this delay is results in a bad result, right? Also, the risk of having heart disease is underestimated in women. many people have this impression that women have heart attack kuch ho hi nahi sakta hai. So that is not true. You cannot underestimate. There is a barrier to accessing care due to social conditioning, the fear and embarrassment in the family. The woman is afraid to take help. And also, when she does that, it's less likely to get tested, even in an emergency situation. So that can also happen. Hence, complications and deaths are more after a heart attack, angioplasty or bypass surgery. So angioplasty also, as I said earlier, if you do it early, then the benefit is more. If it is done late, then you have missed the bus, the damage has already occurred. So that is why complications and deaths are more in women. The other reason is that the patterns of disease in coronary disease is a little different in men and women. So it could be common, but in some women, it is different. For example, in men, the arteries are big, the disease is more focal. In women, the arteries could be tortuous, the disease could be diffuse, and the arteries, the size of the artery could be small. So this makes the treatment also a little difficult. So what is the action that we do? Don't wait longer than a few minutes. If you have any new symptom, trust your instincts and be alert to new symptoms. Inform family members about your symptoms and call a cardiac ambulance, which may take time. So it is better that you are taken to the hospital by somebody as fast as possible, even in an auto rickshaw, if car is not there, but whatever way, reach the hospital the nearest. While going, chew a soluble aspirin, because that will help the treatment later on. And if your blood pressure is known and you have nitroglycerin, you could take it. Otherwise, don't bother. But aspirin would be a good idea, and reach the hospital as fast as possible so that complications or damage after a heart attack can be prevented by prompt opening of the artery within few hours of the chest pain. I hope this much is clear so that we can ask the next question. What percentage of heart attacks are preventable? Up to 10% are preventable, up to 33%, up to 70%, or up to 90%? Well, the correct answer is up to 90% of heart attacks in the community are preventable. Because 90% of heart attacks are due to causes that can be controlled or kind of treated. And what are these? There was this interesting study in 52 countries called the InterHeart study, which found that 90% of heart attacks were caused by one or more of these risk factors like smoking, diabetes, hypertension, etc. And specifically in women, some of these risk factors had a greater impact. For example, diabetes had a greater impact in women. Psychosocial stress had a greater impact in women. And of course, lack of exercise had a greater impact in women. So these are the factors which can be corrected so that 90% of heart attacks can be prevented. Now, in women, there is an additional problem. Besides these standard risk factors that you have in both men and women, women have additional risk factors which could be sex related. The polycystic ovarian syndrome, premature menopause at the age of 40, hypertension and diabetes in pregnancy or preterm delivery, even lack of breastfeeding. So a pregnancy with adverse events is a risk factor, and we have to collaborate with the gynecologist and see that checkups start in such patients, such women after such a delivery, and do not wait, because it is known that the ladies with an adverse outcome during pregnancy have a greater risk of long-term heart disease, heart failure, etc. So the pregnancy is the time, or post-pregnancy is the time to do a proper checkup. Then, of course, women have additional gender-related problems like psychosocial stress, literacy, etc., etc. So now, how to control or remove these causes or these risk factors? So I call this a three-step formula. Step number one, a few measurements that one must take. For example, in routine checkups. Step number two, few lifestyle changes that one must adopt. And step number three, few pills as and when required and advised by the cardiologist. So what are the few? And now the second thing is, as I emphasized, these few lifestyle changes and few measurements are very important after an eventful pregnancy. So in women, this pregnancy is kind of a stress test where we know what can happen in future and take action immediately in the postpartum period. Then step number one is few measurements. For example, blood pressure should be less than 130/80, fasting blood sugar less than 100, HbA1c less than 5.7, cholesterol less than 160 in general, triglycerides less than 150, LDL cholesterol in general in Indian should be less than 100, but in patients who have at high risk, it should be less than 70. Patients who are at very high risk, for example, who has undergone bypass surgery or has multiple heart attacks, the LDL should be less than 50, right? And waist circumference in ladies less than 31, gents less than 35, and the waist to hip ratio should be less than 0.9. And the other measure we like to do is the cardiorespiratory fitness, which is simply measured by the walking speed, which should be more than 400 meters in 6 minutes. This is very rough estimate, but in general, I can tell you that people who walk very slowly are at higher risk in future. And the interesting thing is that the walking speed can be increased. So even if you are a slow walker, if you have any problems, musculoskeletal or any other medical problems, you can solve them and start practicing walking fast, right? Then step number 2 is few lifestyle changes. This all you know very well: to stop smoking, take it food which is low in sugar and salt, low in refined starch, absolutely no trans fats, lots of fruits, vegetables, whole grains, nuts, legumes, etc. Regular exercise, aerobic exercise 7 days a week, half an hour every day, and strength training 4 days a week. Stress reduction with yoga, meditation, close relationships, psycho-spiritual treatment, etc. And a very important risk factor is lack of sleep, and hence sleep also should be ensured and should have regular 7 to 8 hours of sleep in 24 hours. So a few lifestyle changes is the second step. And now coming to lifestyle changes, one question is, are your genes your destiny? Well, not at all, because lifestyle and your mental attitude can, of course, treat your risk factors like hypertension, sugar, cholesterol, and obesity. But very important, the lifestyle and your mental attitude cannot change the structure of your genes, but can change the gene expression. That means what work the genes do. So certain genes can be switched off or switched on by lifestyle and mental attitude. So we should never say that my genes are my destiny. If my father has a heart attack, doesn't mean I will have it, because it all depends on my lifestyle and my mental attitude. Okay, so that was about lifestyle. And the final third step is few pills. We all talk about the statins, which lower cholesterol, which is very important. Low dose aspirin, but not for everybody. This is to be given only after guidance from medical profession. And of course, pills for hypertension, diabetes, etc. if required, all under medical guidance. Statins, are they good drugs? Yes, in appropriate people, after risk-benefit conversation with your doctor. Always have a conversation. What is the risk if I don't take? What is the risk if I take versus the benefits? Statins not only reduces blood levels of cholesterol, but also stabilizes and regresses the fatty plaque. For example, you have a fatty plaque like this in your artery, and if you take a high-intensity statin, the plaque can reduce and stabilize and never rupture and cause a heart attack. So statins have this benefit. We, of course, measure its benefits by noting the blood cholesterol level, but the actual benefit we want to see is in the coronary arteries. So these are the effects of statins. Hence, if you prevent with these 3 steps of few measurements, few lifestyle changes, and a few pills, you can prevent 90% of heart attacks, right? Another 5% you can prevent by the warning symptoms, which can come a few hours or few days before a heart attack, which occurs in 50% of people. And the rest, even if you have a heart attack, if you recognize it early, take prompt treatment, then, as I said earlier, opening that artery fast will prevent damage to the heart muscle. You'll be as good as normal, right? So that is about heart attack and its prevention. What is cardiac arrest? Well, we saw heart attack was due to blockage of an artery. In cardiac arrest, the heart just stops beating due to some cause. There is an electrical problem, and like electric switch is switched off. In the same way, the heart stops beating, so the blood supply to the body stops. And when the blood supply to the body stops, the organ that suffers the most and the first organ to suffer is the brain. Within 3 to 5 minutes, it starts suffering, and the person may go into a deep coma if he doesn't get blood to the brain within 3 to 5 minutes. And if for 10 minutes there is no blood supply, the person is brain dead. So the most important thing in a cardiac arrest is to supply blood to the brain. So should we take this patient to the hospital? No, unless the hospital is just 1 minute away, please do not rush to the hospital. What you have to do is start treatment on the spot. Okay, and what do? You have to save the brain within minutes. Hence, you compress the chest, and then the second step is the heart, which is stopped beating, you revive that with a shock. And how do you do that? First is to recognize a cardiac arrest. How do you recognize? You witness a person suddenly collapse for no apparent reason. Supposing somebody else has seen such a person collapse for no apparent reason, that person also can be saved. But a person who has collapsed, you don't know when, nobody knows, and he's just lying, then that person may not be responsive at all, may not respond because his heart has stopped beating many hours ago. But if you have witnessed a person suddenly collapse for no apparent reason, and he's not responsive to your shouting or you're shaking both the shoulders, you must tap both the shoulders and say, hello, how are you? And there's no response, then look at his breathing. The breathing should be looked at either by seeing tangentially or putting your hand on the upper part of the abdomen or lower chest and see whether it's moving up and down. If there is no breathing and person is unresponsive, take it as a cardiac arrest. There are other causes of unconsciousness like hypoglycemia or convulsions or a common fit and common fainting, in which the person falls, collapses, but the breathing continues. And hence, if breathing continues, then that is a different thing. But if the breathing stops, then it is a cardiac arrest. And then you have to start your action. And what is the first action? Call for help. This help is required for multiple reasons: to get the AED machine or a defibrillator, to get a cardiac ambulance, to get other people to help you while you do the next step. And that next step is proper cardiac compression. And the third step is using a defibrillator or an AED, which you have seen in airports. They are put there and they are used also. So AEDs have to be brought. So these are the three main steps of action that you take. A little detail about the chest compressions. First, take the victim to a firm, safe place. For example, the victim has had a cardiac arrest in the middle of the road. You have to bring him to the side of the road. If a cardiac arrest has occurred on a soft bed in the home, you cannot do cardiac compression on a soft bed. You have to bring the patient down to the floor. Take your position on either side of the patient, okay, and kneel down. And with your shoulders right above the chest, with the elbows straight and the fingers interlocked, with the heel of the palm, compress the lower part of the sternum. How do you know which is the lower part of the sternum? Well, look at the soft part. The soft part you cannot compress. The hard part just above the soft abdomen is the lower sternum. And that is the place where you start your compressions. And that should be 2 inches deep and strong. Allow the recoil, that means chest, to come up after every compression. And it should be about 100 per minute. As you can see here, the heel of the hand is over the sternum, and the compression occurs so that some blood goes to the brain, and this should be 2 inches deep and at about 100 to 120 beats per minute. Nowadays, the AED machines, they have a metronome which will tell you the rate at which you must compress. So this is how the compression should go on, so that the brain receives blood, and you have some breathing time for the brain till the AED machine arrives. And when the AED machine arrives, the first thing you do is open it up, attach the electrodes, the right upper and the left lower chest. I remember LL means left lower chest and right upper. And these are the places where you apply the chest and then switch on the machine, and then let the machine tell you. The machine will tell you that I am analyzing the rhythm, don't touch the victim. And then it says give a shock, or itself, if it is automatic, it will give a shock. And when it gives a shock, the person's heart may revive and he may wake up. But if he doesn't, then the machine tells you that start the compressions again. So about 2 minutes of compression, 1 shock, 2 minutes of compression, 1 shock. That kind of cycle should continue till the cardiac ambulance arrives. So this is how, or till the patient wakes up. So many times this process can go on to 45 minutes or 1 hour also, and patients have been revived. And right now, incidentally, this is a National Sudden Cardiac Arrest Awareness Week from 24th September to 2nd October. And you can log into this website and reviveheartcarefoundation.org and learn about cardiac resuscitation. So summarizing, heart attack means a blocked artery. And what happens? It is a problem of pipes in our heart. The pipes with the water carrying pipes, these are the blood carrying pipes. So it's a blocked artery causing chest pain. Treatment is opening the artery as fast as possible in the hospital. And while on the way, one may take aspirin. So minutes count. You have to take a decision within a few minutes and reach the hospital. Whereas the cardiac arrest is a problem of electric supply. It's like a current being switched off. And so what happens? The heart stops beating and the person collapses. And the treatment is CPR and electric shock on the spot. Okay, and seconds count. So the take-home messages that I would like to tell you are that heart attack and cardiac arrest are different and should elicit different responses from the bystanders. Up to 90% of heart attacks are preventable with the use of the 3-step formula which I mentioned. Period after the eventful pregnancy is very important in women to initiate prevention. And those heart attacks that cannot be prevented can be almost cured by prompt recognition and treatment, which is opening the artery as fast as possible. Also, cardiac arrests are preventable to a lesser extent because cardiac arrests are not due to coronary blockage alone. They are due to multiple other factors which cannot be prevented. And hence cardiac arrest can occur despite our efforts at prevention. Hence, spreading knowledge about recognition and action, as well as availability of AEDs, is very essential. About half of heart attacks and cardiac arrests can be aborted by attention to warning symptoms. Many times, half of these patients with heart attacks have a warning symptom few days before. A small pain, 5-minute pain. If that is recognized and treated, you can totally abort a heart attack. And what about women? Yes, women are from Venus. The causative risk factors are different. As I said, diabetes has a greater impact in women. Mental stress has a greater impact in women. Eventful pregnancy, of course, is women related. Triggers of cardiac events are more mental than physical. In a man, the trigger could be anger, heavy meal, alcohol, exertion, etc. In women, it is more commonly a mental effect. And there is a special kind of heart attack, which I'll show you in a slide. It is called the Takotsubo heart attack, in which there are no blockages in the coronary artery, but purely due to mental or physical stress, a woman gets a heart attack, which can lead to death, but very commonly they recover completely if they are treated early. Then, of course, the disease pattern in women, as I said, is more diffuse and non-obstructive. Many times they don't have an obstruction, but a diffuse disease. The symptoms in many women are atypical and hence they are missed, and hence there is delay in treatment, which causes more complications later on. The awareness of risk in women is underestimated, both by the patient, by the surrounding people, and there are socio-cultural barriers to taking treatment in women, and that has to be broken. So even if the incidence of disease is lower in women, complications are more. So death rates are more in women. And hence prevention is of paramount importance, especially in women. The risk factors like PCOS, premature menopause, and eventful pregnancy. So please be alert to new symptoms, trust your instincts, and reach out for help. This is what I was talking about. This is a normal heart, but due to sudden mental stress, the heart pumping becomes very weak and heart almost dilates, takes the shape of this equipment which Japanese people use. It is called an octopus pot, which to catch octopus. So this is a pot which is called Takotsubo, and the disease is called Takotsubo. Patients may go into severe heart failure with breathlessness, chest pain like a heart attack. Coronary arteries are normal, and slowly within a few weeks and months, the heart becomes totally normal. So this is purely due to mental stress or sometimes physical stress, and 90% of these cases are in women. So is the heart of a woman different? No, it is special. And to protect our heart, the three important steps are prevention, paying prompt attention to symptoms, and taking action. So I thank everyone, especially the Innerweal clubs of the country, for giving me the opportunity, and we can have questions later on. Thank you very much for your kind listening.
Thank you, Akshay. Wow, we got so many practical suggestions on how to handle a cardiac emergency before the doctor can reach. And how should a woman take more care of her heart? Thanks for giving a different perspective of romancing the heart of a woman by the woman. Dr. Akshay, you have President Sejal and Secretary Kavita Rege from Innerweal Club of Bombay West waiting outside your clinic. That's a surprise. So please
Okay.
Be outside your clinic door.
Oh,
Our Innerweal members are waiting there to
okay.
felicitate.
Okay, great. I'll call them in. Sure.
Yeah.
Okay.
Yeah. On behalf of District 314 and the Project Committee of Medical Awareness Seminar Committee,
Oh, so there they are. What a surprise. Wow. Only women can give surprises like this. Thank you. Thank you so much.
Yeah, I think we should show.
Yeah. I'll just change the. Yeah. Okay.
Hi.
There they are.
hi, Kavita.
Okay. So you can see them. Thank you.
Hello.
Yeah. Wow.
Thank
Yes.
you.
Thank you so much.
Sejal Rawal.
Oh, wow. So beautiful. Thank you so much. Real surprise. This I've never seen this. Thank you.
Thank you.
Okay.
Yes.
Have a seat.
Yeah.
Or you want to go or you
We'll go.
You can sit
You
here.
can continue because your
Yeah.
question.
Yeah, questions. Okay. Thank you. Thank you so much.
Friends, now we take the awareness further with our second speaker, Dr. Chandrasekhar Ponde.
Sure. Please be comfortable. You would like to.
He will speak on being hyper about hypertension. His illustrious academic and career graph will be presented by Dr. Sonal Raje. Sonal.
Thank you, Dr. Pallavi. Well, let's go ahead to Dr. Chandrasekhar Ponde. He hails from the beautiful city of Solapur. He has completed his post-graduation in medicine and specialization and post-graduation in cardiology too. He has received fellowship in interventional cardiology and electrophysiology from Brisbane. Dr. Ponde is a recipient of several awards like Paul Harris Fellowship in 1995, Olympian Health Award in 1997, Rashtriya Man Seva Puraskar in 2006, and National Primetime Award in 2016. He has up to 100 publications in various national and international journals and has delivered more than 500 lectures in various national and international conferences. He has received Inspiring Cardiologist of India Award by Economic Times in 2020. Dr. Pandey was the national president of Indian Academy of Echocardiography 2021-2022, and he is currently practicing as a consultant cardiologist and head of Department of Cardiology in Hinduja National Hospital, Mumbai. So let's go ahead and listen to how we cannot be hyper with the talk of Dr. Akshay Mehta and control our blood pressure. So over to you.
Thank you.
I want
Thank
to
you, Doctor.
say something. Dr. Pandey, I just want to tell the participants that when I communicated with Dr. Pandey regarding the seminar, he appeared so cool that being hyper will be impossible for any of us after his talk. Dr. Pandey.
Thank you very much, madam. I thank immensely for this invitation, which has been a real heartening thing, and it's indeed an honor and a privilege to be here with you all, Dr. Pallavi, Yogini madam, Dr. Sonal, and Mrs. Kaur, and everybody. So let me share my screen. Am I audible well?
Yes, you are.
Yeah. So now, can you see the slides now?
Yes, very, very distinct.
Okay. So being hyper about hypertension, the question is, should you be hyper about hypertension? Well, we will derive to an answer yes or no, hopefully by the end of this speech. So initially when the talk came to me as a topic, I was wondering whether I should be talking absolutely colloquial without much of scientific flavor or knowledge in it, or whether I should be purely scientific and not at the baseline, or I should be a mix. So at the end of that, all 15 minutes of thinking, I said I should be a mix of both of that. So I have made a speech, this presentation, which will derive scientific information and also will tell you how to go about this, managing blood pressure if it exists in one of the family members or you yourself or any of your patients. Okay, what is the definition of hypertension today? I'm telling you, when I was a medical student, 150/90 was accepted as okay kind of a blood pressure. General practitioners will say, nahi, ye aapki umar mein ho sakta hai, 150/90 acceptable, no more. So now, normal blood pressure below 120/80, the moment it crosses 120/80, it is considered elevated. 130 to 140 systolic, 80 to 90 diastolic is stage 1. Anything beyond that is stage 2. So mind you, if you have 150/90 blood pressure today, you have stage 2 hypertension. Now you'll ask me, Dr. Pandey, why such a dramatic shift in the definition has occurred over just 2 or 3 decades? I will give you the explanation of that in a while. So 120 and above is elevated. More than 130 systolic is definitely a hypertension. So if you look at it, the green signal is 120/80, yellow signal, which is elevated, but may not need pharmacological treatment, is 120 to 130 systolic. Above 140 is all red and darker red. So this is the way one should look at the blood pressure values. On the top of that, patients with diabetes, patients with kidney disease, in them, anything above 130/80 is considered stage 2 straight. So their optimum blood pressure is below 130/80. And there are 2 separate classes. One is primary hypertension, where there is no definite cause of the blood pressure. Maybe there is a family history, maybe few of the family members are affected, and maybe the community in which the patient is grown has a very high prevalence of hypertension. I'll give you a classic example of such a community: African Americans. typical people with very high prevalence of hypertension. And Japanese, extremely low prevalence of hypertension. So there are races where the incidence is very low, and there are races where the incidence is very high. The remaining have some definite cause, like narrowing of the artery supplying the kidney, narrowing of the aorta exiting the heart, some endocrine disorders like a tumor on the top of the kidney called adrenal gland tumor, etc., etc. They are exceedingly rare, exceedingly rare. That means not more than 5% of hypertensive people have secondary hypertension. Patients do ask me, what are the symptoms of blood pressure, doctor? And I keep on saying, consider hypertension as a silent killer. And that is the truth. Unless the blood pressure is extremely high, and unless it produces a complication like a stroke or a paralysis or a heart attack or a heart failure, many people don't even come to know. Many? How many? 50% of people don't even come to know. They present with a complication. But yet, in the early phases, there are some symptoms. Headache and dizziness, unwarranted palpitations, easy fatigability, impotence in a young, unexplained hematuria, not disturbances of vision, angina, breathlessness, and episodic weakness of one arm or one leg. They all can be the symptoms of blood pressure. Now let us understand the magnitude of problem. Look at this. 1 billion people worldwide suffering from hypertension. But what is worse, this figure is going to increase by 60% in 2025. And 1/3 of these not even aware that they are hypertensive, because they are never checked. That is why it is called a silent killer. And they may present with complications like stroke, MI, kidney failure, or heart failure. Hypertension affects 4 major organs: brain, all the blood vessels, heart, kidneys. These are the 4 major organs affected. The 5th organ, which is also, I consider, quite important organ, is eyes. So retinopathy can occur and you can develop blindness. So these are called target organs which are affected with blood pressure. So anyone and everyone who comes to my office, okay, I must make all the attempt to know whether the target organs are already started getting affected. How do I do that? If I check urine file microalbumin, it is positive, kidney is already started getting affected. If my echocardiogram or ECG shows left ventricular hypertrophy, heart is getting affected. If my arteries are stiff on Doppler, the intima media thickness is increased, my arteries are getting affected. If in my brain I have had a TIA episode, or I have symptoms of unexplained headache, dizziness, loss of memory, short-term memory, of course, the brain is getting affected. Most people with hypertension do not have it under control. Another extremely sad fact. If you take 100 patients with blood pressure, only 50% know that they have it. Only 1/3 of them, they treat it, and only 15% are controlled. And that is really, really a horrible fact of life. On the other side, look at the benefits. A reduction of only 20 millimeters of mercury will reduce the incidence of heart attack and stroke by 50%. 50%. That is such a huge benefit by a small reduction in the quantum of blood pressure. And it's a myth that blood pressure only affects elderly. 15 million people in 2015 died of non-communicable diseases, and the major non-communicable disease out of that was hypertension. Hypertension kills nearly as many people worldwide every single year as all infectious diseases combined, including respiratory infections, diarrhea, AIDS, TB, and malaria together. So it's not only a silent killer, it is a silent, devious villain killer because it is not diagnosed, because it rarely produces symptoms, because the symptoms it produces are so subtle, they are mistaken for sometimes acidity, sometimes overwork, sometimes mental stress, sometimes even blamed on marital dispute. And blood pressure is never diagnosed. How to measure blood pressure accurately, right? Stephen Hales, this man, in 1721, inserted a small tube into the carotid artery of a horse and said, the blood pressure of a horse is 8 feet 3 inches of water. He measured it in just heights in the tube. He had nothing else to measure. No mercury manometer, no spring manometer, automated devices out of question. So that was the first blood pressure measurement in an animal ever recorded in the history. 100 and more years had to pass when Rivarossi invented this first mercury sphygmomanometer and published it in the France Journal of Medicine in 1896. Norman Kaplan, currently called the father of hypertension, said measurement of blood pressure is such a procedure of great importance, but performed in the sloppiest manner. Those who are doctors here will agree with me. Now, I will show you one slide. Which blood pressure measurement to accept? Office blood pressure or home blood pressure? Okay. Or ambulatory blood pressure. Home is taken by the patient himself at home with an automated machine. Ambulatory, a digital machine attached to the vest, which takes automatically blood pressure for 24 hours. Every 1 hour in the day, every 2 hours in the night. Let's go through this now. Okay. Now, the American College of Cardiology, American Heart Association, European Society of Hypertension, and the NICE guidelines, they all say that when the physician measures the blood pressure in the office, he has to follow all this. Now, any one of you can tell me if single doctor on the planet has practiced all this. Quiet room and comfortable temperature. Before measurement, see to it that the patient has not smoked or taken coffee or exercise for 30 minutes. He has emptied his bladder. He has sat on the chair. He should not talk to the staff before, during, or between the measurement for at least 5 minutes. He should be seated with the arm resting on the table, with the blood pressure apparatus at the mid-arm level, electronic or mercury. And his back should be rested on the back of the chair. The cup should be appropriate to the arm size. And you should have at least 3 measurements 1 minute apart and average them, discarding the first one. And in the first visit, measure the blood pressure sitting and standing, and both the arms and at least one leg. You must be joking, right? You said, Dr. Ponde, you must be kidding. No doctor can take such a blood pressure in such a meticulous manner. And if he takes this, he will have to retire from his practice at the age of 40 probably, because he will have no time to practice remaining. He will age so soon. But this is the way the blood pressure has to be taken. Now, this can be taken only by the patient himself or his spouse in his own home, in a comfortable air-conditioned atmosphere, when he's sitting, nobody talking to him, not a busy clinic of a doctor, and so on. And therefore, home blood pressure measurement has become the standard of care of all the international guidelines, contrary to what you may be thinking or contrary to your belief. Now, look at this. The factors which increase your blood pressure: talking by 7 to 10 millimeters of mercury, listening 5 millimeters of mercury, crossing the legs during blood pressure measurement 8 millimeters of mercury, no back support 10 millimeters of mercury, arms unsupported systolic 1 to 7 millimeters of mercury, arm position with the center of the bladder at the heart level good, below the heart level increase in the blood pressure, full urinary bladder 15 millimeters of mercury, recent coffee intake 10 millimeters of mercury, recent smoke 6 millimeters of mercury, a cuff worn on the sleeve of the shirt another 5 millimeters of mercury. A too small a cuff for an obese woman or an obese man, 10 millimeters of mercury. So please understand that measurement of blood pressure is to be taken with an attitude, preferably not by a clinician because they are too busy to do that. We have in our hospital a clinical nurse in our wing who makes the patient rest in a separate room, which is another consultant's room, who's not consulting on that particular day, a free room, air conditioned, mildly lighted, and she takes it after 10 minutes of rest. So you must have experienced this. Once we finish with your blood pressure, we need to find out why your arm is purple. Some doctors raise the pressure in the cuff so much that the patient literally screams, "Oh, no." And can you imagine what that blood pressure reading will be? Definitely high, right? So, which is better, office measurement or home measurement? And several hundreds of studies have occurred, hundreds of studies. The net is full of them, because when your blood pressure is normal in the office and at home, it is called true normotension. When both the places it is high, it is hypertension. When in the office it is high, but the home it is normal, it is white coat. And the reverse, in the doctor's office, the blood pressure is normal, but at home it is high. I'm sorry, I'm not blaming the spouses here at all. Please don't misunderstand me, right? So home blood pressure high, but the office normal is called masked hypertension. Now you will ask me, Dr. Ponde, cut this crap. Okay, how do you know this patient has masked hypertension? He comes to my office blood pressure is normal. If the office blood pressure is normal, but the patient has unexplained headache, the office blood pressure is normal, patient has unexplained left ventricular hypertrophy on the ECG. Office blood pressure is normal, patient has unexplained rise in uric acid. Office blood pressure is normal, patient has mildly elevated creatinine, unexplained. Please exclude masked hypertension. Please do that. Give the patient home blood pressure measurement and you will be surprised. And I will show you one of our beautiful landmark study which we did in our own country. So this study done several years ago, 2015, 831 patients studied in the office. 608 had normal blood pressure. 608 had normal blood pressure in the office. When they were sent to home for home blood pressure monitoring, almost 166 had high blood pressure at home. So they were masked hypertensives. How many percent? 18%. On the other side, at office, when 223 had high blood pressure, out of that, 61 were completely normal at home. They were white coat hypertension. So please remember, white coat hypertension, which is high in the office, normal at home, is a reality, not a myth. And on the other extreme, normal blood pressure in the office and high at home is even a bigger reality and certainly not a myth. Please get awakened. So home blood pressure classifies office measurement into white coat and mask. So all the guidelines nowadays recommend home blood pressure, home blood pressure, home blood pressure. Office blood pressure alone is not enough for diagnosis. Home blood pressure also correlates better with the risk than the office blood pressure. So if the patient has persistently high blood pressure at home, he will have adverse prognosis as compared to the patient who has only high blood pressure in the office and not at home. And there are two best BP instruments available. Those who have your mobile on, you can take a screenshot maybe. Omron HEM 7130 is the best internationally validated BP machine. And on the right side, Circa 12080 is again accredited by European Society of Hypertension, American Society of Hypertension, Indian Society of Hypertension, and NICE guidelines. These are the only two blood pressure machines available in the market which are US FDA approved. So please don't use anything and everything that is available in the chemist shop. Please use the approved one. Going ahead, home blood pressure is very, very feasible. 10 minutes of training are sufficient. And when do you measure? You take 3 readings in a day. 1, early morning, when you get up, but before you brush your teeth, before you go to the toilet. 2nd, an hour after lunch. And 3rd, after day's activity, but before dinner. These 3 readings on one single day, one should be a working day and one should be a holiday, will give you tremendous insight into the patient's blood pressure patterns. Tremendous insight. And time and again, I have proven to my patients that this is the way to go. In fact, last 7 years, I rarely take blood pressure myself in the office. My clinic nurse takes it. My assistant might take it. And the patients bring their own blood pressure readings from their own home, which are far more valuable than one blood pressure reading in my office. So look at the international guideline recommendation. Out of office BP measurements are recommended to confirm the diagnosis and titration of BP lowering medications, not office blood pressure. So home BP, home BP, home BP is the first message. But however, there are some lacunae. Home blood pressure cannot give information about nighttime pattern. What happens during sleep? You can't tell the patient to or tell the spouse to take the BP during sleep. Morning, a very early morning surge, 5 a.m. surge, you will miss. And 24-hour BP variability. This is given by ambulatory blood pressure measurement. Ambulatory is a machine, a cuff attached to your forearm, a machine on your vest, and the machine just goes on. And then you get daytime blood pressure, nighttime blood pressure, nocturnal dipping patterns, early morning surge, and white coat. That means when you are attached to the machine, the BP is high. Later on, it is all normal. It is white coat. This unbelievable information can come only from ABPM. As a president of Indian Society of Hypertension, Dr. Uday Jadhav had given a beautiful oration a couple of years ago, and he said every single hypertensive patient must have at least once in a year ABPM, because ABPM reveals startling facts. They are 41% of Indian hypertensives are non-dippers, normal dippers, and 60% abnormal dipper. Abnormal dipping means during sleep normally the BP goes down by 20/10. So if your dinner time BP is 130/90, your night BP should be 120/70. Right? If this doesn't happen, you are an abnormal dipper. And in abnormal dipping, there are 3 patterns again. Non-dipper, no dipping at all. Reverse dipper, that means during sleep, the BP on the other side increases. And 4% are extreme dippers. All these are bad. Non-dippers, high incidence of stroke. Reverse dipper, high incidence of early morning heart attacks. And extreme dippers, high incidence of kidney failure. So this information is given by ABPM. But ABPM is not practicable in every patient. 2-tier, 3-tier cities don't have it. So the interim gold is home BP. It has a good reliability and good correlation with complications. So let us all embrace self-BP measurement at home. That will be my very solid message from the first 1/3 of the talk or half of the talk. What are the sad truths about hypertension? Sad truths are only 3/4 of the people in our country are ever screened for hypertension. Only half of them are treated. Only half of them become aware. Only 13% are treated and only 8% are controlled. So Indian hypertensive patients. They have a stress lifestyle, high prevalence of isolated systolic hypertension, higher resting heart rate, common coincidence of diabetes, and early signs of CKD. They are more prevalent in urban than rural population. Large chunk of patients are unaware. Burden of hypertension. 25% rural and 40% of urban Indians above the age of 31 have hypertension. Can you believe that? 40%. So 1 in 4 of us is likely to have hypertension. And equal number are being treated, or only 1/10 are controlled. If you look at the state-wise prevalence, the northern states are highest, southern states are lowest, Maharashtra is somewhere in between. Why to treat hypertension after all? This is the BMJ editorial in 1932, which said, we have discovered blood pressure, but the problem is if you discover, some fool will likely to reduce it. So medical journal said, don't treat blood pressure in 1932. And in 1935, President Roosevelt died of cerebral hemorrhage because of high blood pressure. What a paradox. What a horrible paradox. And since then, we are lowering and lowering and lowering the blood pressure goals. So blood pressure contributes to 35% of cardiovascular death, 50% of strokes, 25% of heart attacks, and 50% of heart failure. Imagine. So we have a very bad, ominous villain to deal with. As I said, 10 millimeter decrease in blood pressure reduces heart attack by 30% and stroke by 40%. And hypertension contributes to more deaths than cholesterol, pollution, smoking, or obesity. Also, target organ damage is very, very frequent. And in India, hypertension is directly responsible for 57% of strokes, 60% of kidney failure, and 25% of heart attacks. So please bring the blood pressure down, is the message. Which blood pressure is more dangerous? Time and again, patients ask me this question: systolic or diastolic? ऊपर का कि नीचे का? क्या डॉक्टर, मेरा ऊपर का बीपी इंपॉर्टेंट है कि नीचे का बीपी इंपॉर्टेंट है? ओके, ठीक है. The biggest study done just November 27, 2000 has shown that isolated diastolic BP carries a very low risk. It is the upper blood pressure, the systolic, which determines your survival. If both are high, obviously you need to treat both. But if suppose your upper is 130 and lower is 90, don't worry too much. But upper is 160 and lower is 80, start worrying. Because it is the upper that is important. India Heart Study we did in 2020. Self blood pressure measurement at home compared to office. I was one of the proud investigators of this study, and we studied 23,000 patients in 355 metro cities in India by home blood pressure. And what we found was that in India, the white coat is 10%, mask is also 10%. And the average heart rate of an Indian hypertensive is very high. See, we are all little hyper individuals in all walks of life. You will rarely see an Indian on a holiday also just soaking in the sun at the beach. They will be planning their sightseeing, packed sightseeing of 20 places in one day. Typical of India. We don't know how to relax. And therefore, our heart rates are higher. So we need non-pharmacological treatment. And this is lifestyle. So avoid harmful habits, give up smoking and alcohol, reduce salt, reduce fat, lose weight, regular exercise, and dash diet. Around 5 steps. So weight loss is important. Quitting alcohol, lots of fruits and veggie, no smoking, regular exercise. In this dash diet. What is dash diet? Vegetables, fruit, only fish is allowed, limitation of red meat and sweetness, salt content less than 5 grams a day. Tomato is for you. Tomato sauce is not for you. Tomato rich in potassium, low in sodium. Tomato sauce high in sodium, low in potassium. Fruits and veggies and a lean meat is for you. High in sodium, but processed meat, burgers, French fries, and artificially sweetened drinks, not for you. Weight loss strategies for prevention, physical activity for prevention has been now proven beyond doubt. And of course, meditation. The lovely art of meditation, we have forgotten. People talk about meditation these days in different contexts. A lot of people take it as an escape path to escape from some unusual, unpleasant situation in their life. Meditation is not for that. I'm sorry. Really sorry. Meditation is a self-search. Meditation is searching the purpose. Meditation is mitigating with obstacles with a quiet mind. Meditation is facing problems with a quiet heart. Meditation is optimism. And meditation is completely coming in terms with your situation and your reality and accepting it with open arms and a quiet heart. That is meditation all about. It is not escapism from the bad things that are happening from your life. Weight reduction reduces blood pressure by 10. Diet 15. Sodium restriction 8. Physical activity 9. And quitting alcohol by 4. So all these reduce blood pressure. But please remember, people might have high blood pressure without any warning signs. Therefore, anyone and everyone above the age of 30 should have less salt, high fruits, no saturated fat, no tobacco, once in a week alcohol maybe, and physical activity. So there are drugs available. These drugs work on 3 paths: volume, heart rate, and vascular resistance. So there are 3 types of patients. I'll give you an example of the middle patient. An obese, young, 30-year businessman, sedentary lifestyle, just goes and sits at the counter in his shop. He has a lot of fat, lot of edema. His heart rate is not very high. Blood vessels mildly narrow. On the right-hand side, I have got a extremely ambitious bureaucrat, a business or a CEO of a corporate, hyper, 20 meetings in a day, 10 tours in a month, very high sympathetic activity, not much of volume, not much of blood vessel problems. On the left side, I have an elderly hypertensive, blood vessels stiffened, not much of volume, and moderate sympathetic activity. And there are drugs different for that. I will not go into details of that today. But the truth of the matter is, majority of the hypertensive need 3 or more drugs to control their blood pressure. 3, not 2, not 1. Let us accept this fact. So non-adherence is the Achilles heel. People giving up drugs. Because they are fed up. There are complex regimens, side effects upper, or cost is prohibitive. And therefore, a lot of combinations have come in the market. These combinations are a practical necessity. In our country, we are blessed to have 250 odd combinations available to us. You name a drug, name a dose, there is a combination. They are required by more than 3/4 of hypertensive. They have greater efficacy. You achieve blood pressure faster to normality and lesser side effects. If you use a single pill combination of amlodipine, beta blocker, and a diuretic, imagine 1 pill a day at bedtime, that's it, and you're done. So drugs, I will not go into details of that, but there are 5 classes: diuretics, alpha blockers, calcium blockers, beta blockers, ACE inhibitors, and ARBs. These form the mainstay of the therapy. Now, one step further. Guidelines indicate that for newly detected uncomplicated hypertension, it has to be an ACE inhibitor, ARB, plus a diuretic or a calcium blocker. If this doesn't control, then you go step 2 and step 3. This is not for you. But please remember that the blood pressure treatment is virtually almost always lifetime, unless there are some modifiable risk factors which you have corrected. Like you have lost 15 kg of weight, you have quit alcohol, you have started meditating, you have given up salt, then you may reverse blood pressure and it may become well under control without a single pill. But in 70% of people, you will require some or the other drug, maybe in a smaller dosage, despite lifestyle modification. Well, that doesn't mean I want to say that lifestyle modification is not required. No, it is the base of the pyramid of treatment. Every drug will come after lifestyle modification, not before. So now I will go. I told Dr. Pallavi Shah that I wanted to give you all a surprise. I'm thankful to all of you because what I'm here today is because of all of you. You will ask me how. I was selected as a Rotary International Scholar in 1994.
Wow.
And went to Australia. These are the 3 other scholars with me. This is a Scandinavian girl. She came from France, and this guy was Chinese actually. So we 4 I went to Australia, and this is my local guardian there, Chris Ellis, his wife, myself, and the governor of Rotary Club of Stafford at that point of time, 1994. I worked a lot on the weekends in the Rotary, teaching the tribal aborigines in Australia about vaccination, blood pressure, salt, diabetes, and hygiene. And Chris Ellis was a marvelous man. And I kept on giving lectures in different Rotary clubs in Australia. This is one in Melbourne. This is Wiley, Queensland, Australia. And with 2 years of 16 or 18 expeditions, the Rotary Club of Australia was good enough and gracious enough to bestow upon me the Paul Harris Fellowship. And this came in the newspaper in Australia that time. You can see here, Stafford International Rotary Scholar Chandrasekhar Ponde says that his study at the Prince Charles had changed his life. And so you have made me actually. So thank you very much. And my final message is, this is my Rotary Paul Harris Fellowship medal. And takeaway message is, hypertension is a major cause of morbidity, extremely common condition, but not diagnosed and not treated, but very easy to diagnose and treat. The aim of treatment is to save damage to the organs, brain, heart, and kidney. Lifestyle modification is the foundation of therapy. Drug treatment is now very simplified, but usually once started is lifetime. Thank you all. Thank you very much.
Thank you, Dr. Ponde. That was amazing information that you gave. And, you know, we didn't realize that you were one of us, and you have benefited Rotary a lot, and Rotary has benefited you. So we are so proud of that. And Dr. Ponde, you have Pooja Madnani
Yes, sir.
and Shubha Lohatia from Innerville Club of Mumbai Khar.
Yeah,
waiting
I'll bring them.
to meet you.
Come. We have to be in the front of the camera. We are here.
On behalf of District 314, Dr. Ponde,
Thank you.
Pooja Madnani and Shubha Lohatia,
Thank you.
Innerville Club of Mumbai Khar.
Thank you, doctor, for the.
Thank you for the enlightening talk.
Thank
Thank you
you.
very much. Thank you.
But we really learned a lot.
You'll have a cup of coffee. You'll have coffee.
Okay, guys. So now that we have expressed our gratitude to the doctors, let us begin with the interaction, which all of you are looking forward to. Because of lack of time, we will restrict the questions to about 1 or 2 to each doctor. And all of you can write down your questions and give it to us. And then we will give you the answers through all the websites you are attached to. Or maybe at the next session, we will give you the answers from these doctors. So Dr. Akshay Mehta, are you there?
Yes.
Okay, the first question is addressed to you. What has been the impact of COVID on heart and heart diseases?
Well, very interesting. You know, in the initial, COVID has affected the heart indirectly in 2 ways. You know, when the epidemic started, a lot of people were afraid of going to the hospital, and we used to find that where have all the heart attacks gone? Hospital mein koi heart attack ka patient nahi aa raha hai. And it so happened that the patients remained at home and took treatment at home. Some died. So that was the impact in the early days. The other impact was that many patients, the exercise stopped and the mobility stopped. So patients became more sedentary. So hypertension and diabetes went up. And of course, finally, what happened was that many patients with underlying heart disease, hypertension, diabetes, when they got COVID, their complications much more, because COVID is an inflammatory condition, highly inflammatory. It affects us 2 things basically: the arteries or the blood artery, the vessels of the body, and the heart. And because of these effect on the vessels, there could be easily clotting in the pulmonary arteries. So people get pulmonary embolism in the veins, and the heart attack, stroke, all that became worse, mostly in patients with underlying disease. So COVID affected us in such a great manner. Fortunately, the long-term effects are not very common. They are there. If you do MRI or echo of patients, you may find, but they are not very serious or very damaging. So that is how COVID has affected us. Fortunately, it is going, and we are much better off right now.
Right. The second question is, previously we were psyched by increased cholesterol, and we started taking statins. So do you suggest taking statin, or we have to ask the doctor and only start it in certain cases? Whether statins can be given for a longer period without side effects?
Yes. Now, the decision to take statins has to be discussed with your doctor. There are certain situations where there is no doubt and there is no ambiguity about taking statins. For example, if a person has had a heart attack or has angina, has blockages in the coronary arteries, which are seen on a CT angiogram or an angiogram done as a part of routine, very rarely, that is not normally done. but many times CT angiographies are done and blockages are seen. When you have a blockage, whether it is seen on a test or it is caused symptoms, once you see that, it is always a good idea to take statins. And if there are side effects, one can change the statin, the type of statin. There are other drugs which have come now, which can reduce cholesterol. So those are the patients, there is no doubt that statin should be given. Now, when you talk of person who has not had any blockages or any symptoms, whether to take statins or not, just on the basis of a high cholesterol reading, that is not a good idea, because we are giving statins to depending on the risk of the patient, not the cholesterol level alone. Many times cholesterol level is very high, more than LDL cholesterol, more than 190, 200. Such a patient, we definitely give a cholesterol pill, a statin. But a person who has 130, 150, 140, it all depends on the risk of the patient. If the patient is at high risk, depending on multiple other risk factors, like if a patient has hypertension, diabetes, a family history, and is sedentary, obese, so such a patient is at high risk, and for them, we have to discuss the pros and cons of taking a cholesterol pill, a statin, and then decide.
Yeah. Thank you, doctor. We'll come back to you after putting some questions to Dr. Ponde. So Yogini, please, over to you for the questions for Dr. Ponde.
Hello, Dr. Ponde.
Hello.
There was so much information. There's a question that if both the parents are hypertensive, then the child, at what age you will start measuring his blood pressure? If there is a genetic history.
Measuring at the age of 18.
18.
Yeah, 18. Yeah. Because if both the parents are hypertensive, it is very possible that with the current lifestyle of fast food, sedentary lifestyle, etc., people might declare their hypertension almost a decade earlier. So we must start measuring at the age of 18.
One more question. You showed us the forearm digital, BP measurement instrument. In the market nowadays, there is a radial also available, which has come recently.
Yeah,
Do you recommend?
there is a lovely study about radial versus arm. So the radials are good if your arm is of medium size, but if the arm is too small or too big, radials can go very wrong. So radials are not really recommended.
Radials means at the wrist. Being a doctor,
At the wrist, correct. Yeah, arm at the wrist like this. It is not recommended.
Not recommended. Thank you, doctor.
Sonal, do you have questions for Dr.
Yes,
Ponde?
well, we have many questions. I think we won't be able to answer all, but I'll just cover a couple of them. So we spoke about blood pressure in children. What is the normal range? I mean, if a young child has blood pressure checked, so does the range change compared to adult?
Yes, sure. The blood pressure, pediatric hypertension is a topic by itself. So there are charts and normograms for the age below 1 year, then 1 to 6 years, and 6 years and above. That is 6 to around 12 years old. So there are normograms, and you have to go as per the normograms to diagnose hypertension in children. Yeah.
Okay. So, I mean, what is the range like around, say, 9 to 10 in that age group?
Yeah. Suppose a 10 years old child should have a systolic below 90 and the diastolic below 60. 90 by 60 will be a normal range of 9-year-old child.
I see. And another question which I would quickly like to ask is thyroid disease like hypo or hyperthyroidism. Does that affect the blood pressure, or does it lead to incidences of heart disease?
Yeah, of course. See, hyperthyroidism, that is increase in the thyroid hormone activity or thyroid gland activity, usually causes the systolic blood pressure to go up and the diastolic to go down. So the pulse pressure difference between systolic and diastolic increases. Whereas hypothyroidism usually causes mild increase in both systolic and diastolic blood pressures. Very mild.
Thank you,
So-
Sonal,
Thank you.
for the nice questions you have raised. I wish that this interaction with doctors goes on and on till all the queries are satisfied. We will make a note of the questions that remain and we will put them down and give the answers either next session or on other Innerville websites. So now I request Association President Surjit Ji to give the closing remarks.
It is indeed very encouraging to see such a positive response from our members to our call for the medical awareness seminar. Either our sessions are becoming very interesting or you people are becoming more aware and conscious, or both. We would definitely like to take the credit, some of it at least, for this unique initiative of past International Innerville President, Dr. Pallavi Shah and District 314. Hope you all have benefited by today's inputs. A perfect example of the more you know, the simpler you put it across. Now, I'm sure you all have realized that BP measurement, the blood pressure measurement, by itself is a big subject. I was really it was informative even for me at this stage. We thought we knew it all, but no, there is so much for us to learn. And so elaborately put in such an interesting way, Dr. Ponde put it across. I'm sure you all must have really liked it, that so many of us must be doing it the wrong way. So let us all get down to getting our blood pressures of ourselves, our near and dear ones, and our patients, all those who are doctors, in the very correct way. And Dr. Mehta also handled such a complicated subject in a very simple way. So I'm sure you all your myths are done away with, and you begin improving your cardiac health as advised by today's experts. Thank you.
Thank you, Dr. Surjit. On behalf of the entire team, उनको डिस्ट्रिक्ट 314 की ओर से थैंक यू तो बनता है। आभार विधि के लिए आ रही है डिस्ट्रिक्ट वाइस चेयरमैन पल्लवी चौकसी।
Good evening, friends. We have understood today that no beauty shines brighter than a healthy heart. Our sincere gratitude to the organizers of this project, National Medical Awareness Seminar, Association President Dr. Surjit Kaur, District Chairman Meeta, Project Chairman Dr. Pallavi Shah, Project Coordinators Dr. Yogini Sheth and Dr. Sonal Raje for the exemplary teamwork to present this program together. Words are not enough, so on behalf of all of you, I sincerely thank Dr. Chandrasekhar Ponde and Dr. Akshay Mehta for sharing excellent and valuable information in a simple way to create awareness and have answered all our questions so patiently. Gratitude to all the association and district dignitaries for their gracious and encouraging presence. Thank you all Innerville members and participants for adding value to the seminar. Thank you, Mr. Biswajit, for the technical support. Live healthy and stay young at heart. An important announcement is that the next session of medical awareness will be on 29th November on mental health. After COVID, mental health has gained a lot of prominence. We will have the popular Dr. Harish Shetty to deal with this problem. Happy Diwali to all, and please all rise for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Now we have the questions for the good listener.
Yeah, they will be projected on the screen and kept there for 3 minutes.
So friends, you can take a screenshot or click a picture on your mobiles of these questions and email them on the email ID which is mentioned. So the first 3 with the correct answers will be recognized during our district conference and will be awarded too. So I think don't waste time. Let's just get to it and send our answers quickly. Thank you. We can share the page also, Dr. Pallavi, maybe. I think people must have taken the screenshots.
I think we have given enough time for the screenshot. Thank you all very much. See you at the next session. Bye.
Thank you and goodbye. Thank you.
Thank
Thank
you.
you.
Thank you, everyone.
Thank you.